Hello everyone, welcome to our module on the musculoskeletal system. This is Dr. Nerd. Brachial plexus, it consists of 5 nerves formed by the joining of 5 spinal nerves. It's the source of both motor and sensory innervation of the upper limb. Major brachial plexus injuries, upper brachial palsy, it's an injury of the upper roots and trunk C5 and C6, usually results from increase in the angle between the neck and shoulder. It's a combination lesion of axillary, suprascapular, and musculocutaneous nerves. As a result, the patient will have the waiter's step hand, which is adducted shoulder, medial rotated arm, extended elbow, in addition to the loss of sensation of the lateral aspect of the upper limb. On the other hand, lower brachial plexus injury may occur when the upper limb is suddenly pulled superiorly. It will affect C8 and T1. It may occur when the patient is grabbing support during a fall, as a birth injury, or if the patient is having thoracic outlet syndrome. Musculocutaneous nerve, it's derived from the spinal nerves C5, 6, and 7. An injury to the musculocutaneous nerve might be caused by the upper trunk compression. The patient will have loss of forearm flexion and supination, loss of sensation over the lateral forearm. Axillary nerve, it's derived from the spinal nerves C5 and C6. A fractured surgical neck of the humerus or anterior dislocation of the humerus might affect the axillary nerve. The patient will have flattened deltoid, loss of arm AB duction, loss of sensation over the deltoid and the lateral arm. Radial nerve is derived from the spinal nerves C5, 6, 7, 8, and T1. If the patient had a mid-shaft fracture of the humerus or compression of the axilla, radial nerve might be injured and the patient will have a wrist drop like what you can see in the picture. The grip strength will be decreased and loss of sensation over the posterior arm and forearm in addition to the dorsal hand. Median nerve is derived from C6, 7, 8, and T1. A superior condylar fracture of the humerus or carpal tunnel syndrome might affect the median nerve. The patient will have loss of the wrist flexion and flexion of the lateral finger, thumb opposition, lumbricals of the second and third digit, in addition to loss of sensation over the thenar emesis, dorsal and palmar aspect of the 3.5 fingers. Ulnar nerve is derived from C8 and T1. We have what we call the funny bone syndrome, which is a fracture of the medial epicondylar of the humerus, which will cause an ulnar nerve injury. The patient will have ulnar claw on the digit extension, loss of wrist flexion and deflection of medial fingers, loss of sensation over the radial 1/2 fingers plus the hypothenar emesis. This is a visual picture of the dermatomes. Now the blood supply of the scapula. The arterial anastomosis of the scapula happens when there is blockage of the subclavian or axillary artery, which can be bypassed by anastomosis between branches of the thyrocervical and the subscapular arteries. The anastomosis is composed of transverse cervical, suprascapular, subscapular, circumflexoscapular arteries. This is also a visual picture of the blood supply of the upper hand, starting from the aorta, then the subclavian artery, axillary artery, brachial artery, which will give branch to the radial and ulnar arteries. Here we can see the blood supply of the elbow and the collaterals. This is the blood supply of the hand. We can see the radial artery and the ulnar artery giving rise to the deep and superficial palmar arches. Now let's talk about the lumbosacral plexus. It consists of many nerves formed by the joining of several spinal nerves, L1 to L5, in addition to S1 and S4. Let's start with the femoral nerve. It's derived from L2, 3, and 4. It has a sensory and motor innervation. Sensory innervation, it innervates the anterior thigh and the medial leg. The motor innervation, it innervates quadriceps, iliopsoas, pectineus, sartorius. And a pelvic fracture might injure the femoral nerve that will cause decreased thigh flexion and leg extension. Now the obturator nerve, it's derived from the spinal nerves L2, 3, and 4, and it might get injured in pelvic surgeries. The patient will have decreased thigh sensation in addition to decreased adduction of the leg. The sciatic nerve is derived from L4, 5, S1, 2, and 3. If the patient had a herniated disc, this nerve might be affected. And the sciatic nerve divides into the common peroneal nerve and the tibial nerve. Tibial nerve is derived from L4, 5, S1, S2, and S3. Damage results in loss of plantar flexion, so the patient can't stand on the tiptoes. Common peroneal nerve is derived from L4, 5, S1, and S2, and injury results in loss of dorsiflexion, so the patient will present with drop foot. Lateral femoral cutaneous nerve is derived from the spinal nerves L2 and L3. Tight clothing, obesity, and pregnancy are risk factors for damaging the lateral femoral cutaneous nerve, and the patient will present with decreased thigh sensation in the anterior and lateral part. This is a visual picture of blood supply of the lower limb. Starting from the common iliac artery, it will divide into the external iliac artery and internal iliac artery. External iliac artery will continue to give the superficial femoral artery and giving a small branch which is the profunda femoris artery. Superficial femoral artery will continue to give the popliteal artery, and then the popliteal artery will give you three branches: anterior tibial artery, peroneal artery, and the posterior tibial artery. This is a picture of the anastomosis of the lower limb. We have the trochanteric, which supply the head and neck of the femur. We have the genicular anastomosis. It compensates for the narrowing of the popliteal artery during prolonged knee flexion. And we have the cruciate, which supplies the blood to the lower limb in case of femoral artery ligation during surgeries. This is a slide about the femoral triangle. It's an anatomical region under the inguinal ligament. So superiorly, you have the inguinal ligament. Laterally, medial border of the sartorius. Medially, you have the adductor longus. It contains femoral nerve, femoral artery, femoral vein, and femoral canal. And its clinical importance is to palpate the femoral pulse and to see if the patient has any femoral hernia. This is the popliteal fossa. It contains the popliteal artery, popliteal vein, tibial nerve, common peroneal nerve. And its clinical implication is to diagnose any popliteal aneurysm or also to look for the popliteal pulses. Thank you very much and best of luck.